Posterior vitreous detachment. Introduction. Posterior vitreous detachment, PVD, refers to separation of the cortical vitreous along with the delineating posterior halo membrane, PHM, from the neurosensory retina posterior to the vitreous base. PVD occurs due to vitreous gel liquefaction with age, syncytial, to form fluid-filled cavity, as shown in figure 16.22a. Okay, and subsequently condensation, syneresis, with access to the pre-retinal space allowed by a dehiscence in the cortical gel and or PHM. The prevalence of PVD increases with age, and an individual in their 80s is likely to be at least 60%. It is typically spontaneous, but can be induced by events such as cataract surgery, trauma, uveitis, and panretinal photocoagulations. The time taken for PVD to complete after initial is believed to be variable, but probably occur in stage over the course of months in many patients. Perifoveal halo detachment is followed by foveal separations, then detachments from the posterior retina as far as the equator, attachment initially being retained at the optic disc. Subsequent complete detachment of the cortical vitreous as far anteriorly as the vitreous base takes place. With the exceptions of the vitreous base, physiological attachment to the retina and other structures are disengaged in the course of a normal PVD. Complications may or which require treatment occur in up to 20%. Clinical features. Symptoms are usually, though not invariably, present. Flashing lights or photopsia in PVD is often described as a lightning-like arc induced by eyes or head movement and is more noticeable in dim illuminations. It is almost always seen in temporal periphery. The mechanism is uncertain but may be related to tractions on the optic disc and possibly at the site of vitreoretinal adhesion, including actual or potential retinal tear. Floaters, myopia, are mobile vitreous opacity, most evident against a bright pale background. They are often described as spot cobwebs or flies or masking volatile and are commonly present in individuals without a PVD, especially myopes. A wise ring is the detached former attachment of the margin of the optic disc and may be seen by the patient as a circle or other large solitary lesions. Its presence does not necessarily indicate total PVD, nor does its absence confirm the absence of a PVD, since it may be destroyed during the process of separation. A floaters can be induced to vitreous blood. A blurred vision. A diffuse haze may be due to dispersed hemorrhage within the vitreous gel and a variable accompanying reduction in VA. Bleeding can arise from a torn retinal blood vessel or from the site of a retinal break. Blurring can also be caused by a visually significant PHM or floaters in the visual axis, which may be also cause impairment, usually slight, of acuity. Sign. The detached PHM can often be clinically on slit lamp, examination as a crumpled translucent membrane in the mid-vitreous cavity, behind which the cavity is optically clear. Hemorrhage may be indicated by the presence of red blood cells in the anterior vitreous and as usually small focal intragel collections, or pre-retinally, when it sometimes forms a crescent-shaped borderline, the limit of PHM detachment. Its presence should prompt a careful search for a retinal break, 40 to 49%, particularly with large amount. In such case tends to be posterior. Pigment granules in the anterior vitreous on slit-lamp examination, the Schaffer sign or tobacco dust, are larger, darker, and less reflective than red blood cells. Their presence raises the possibility of a retinal break, up to 95% sensitivity, with loss of continuity along communications between the RPE and the vitreous cavity. Vitreous gels, if numerous, may signify the presence of a break. Retinal breaks, see below. Investigations, you got B scan ultrasound, can demonstrate the extent of the PVD. OCT can show posterior pulse separations. Management. A patient with substantial acute symptom of a PVD should be examined as soon as practical, usually within 24 to 48 hours, with greater urgency in the presence of risk factors including myopia, a past or family history of retinal detachment, high-risk syndrome such as Stiegler's, pseudophagia, and symptoms such as a visual field defect. Reduced vision or very prominent floaters. Inquiry should be made about the presence of any condition predisposing to non-PVD vitreous hemorrhages, usually diabetes mellitus. If there is only a single small floaters and no photopsia, evidence suggests the risk of retinal break in the symptomatic eye is insignificantly higher than of the asymptomatic fellow eye, so that urgent assessment may not necessarily be required. Examination. The anterior vitreous should be assessed for the presence of blood and pigment. Carefully retinal examination including visualization of the orbs serrata, vitreous degenerative changes. This should be performed and should generally include binocular indirect ophthalmoscopy or contact lens scleral indentation. An asymptomatic fellow eye should always be examined. If 10 or more vitreous cells are present in a 1 mm slit lamp field, the incidence of a retinal break in the fellow eye, asymptomatic eyes, have been reported as over 30%. Subsequent management recommendations for review vary, and the following is a general guide. If there is no suspicious finding, e.g. vitreous blood, on examination and no pre-existing risk factor as discussed above, then routine review may not be necessary, and the presence of features associated with higher risk should lead to review after an interval of 1 to 6 weeks, depending on individual characteristics. Some authorities recommend further review 6 to 12 months. Patients who present with multiple prominent floaters or hazy vision should be reviewed carefully, as this has been found to be associated with a higher risk of retinal break. Discharge patients should be given clear instruction, emphasize the need to re-attend urgently in the event of significant new symptoms. Optimally written information reiterating the advice should be provided. Assurance can be given that in most cases the floaters will resolve and become much less noticeable with time. Through exceptional vitrectomy is necessary, though exceptional vitrectomy is necessary. If an area of fundus cannot be viewed clearly due to obscurations or by blood, then weekly review is prudent. Presentation with diffuse fundus obscuring vitreous hemorrhage in the absence of condition predisposing to non-PVD vitreous hemorrhage is associated with a very high risk of retinal breaks, 90%, and retinal detachment, 40%. A relative aphant pupillary defect should be excluded, and B-scan ultrasonography performed regularly until resolution is in order to exclude an underlying detachment or unidentifiable break. A very low threshold of vitrectomy should be adopted, particularly in the absence of other risk factor, notably prior retinal detachment in the fellow eye. The management of retinal breaks is discussed below.